Welcome, everybody. This is Rush University Medical Center Division of Nephrology Renal Biopsy Conference for November 18th, 2021. We're glad to be back. We took a couple weeks off, one for Kidney Week and one for Baxi Week. He actually does get a vacation once in a while. Welcome back. We need you. We can't run it without you. So we're glad to be back. Next week we'll be off because it's Thanksgiving, and then we'll pick it up again. But we've got a great case today. Dr. Baxi is going to be presenting. I see some new faces in the audience. I also see two new board-certified internists, nephrologists, Dr. Blank and Dr. Zhang, are fellows that just got their results. Congratulations, guys. Great job. We're proud of you and happy to join that you're joining the club. As usual, we have nothing to disclose. The case has been de-identified. It is for CME credit. We'll run the CME credit number by you again at the end. And if you have any comments, put it in the chat board and we'll get to it. And without further ado, Pravir, you want to walk us through this case?
Absolutely. Here, I'm going to share the PDF with everyone. So for those who can't see the screen, you'll have a PDF version. Give me a second here. So we have a 50-year-old Hispanic woman who has a history of prior stroke, migraines, and hypertension, whom we were consulted for AKI, hematuria, and proteinuria. So in terms of her stroke history, she had a left MCA stroke about 6 years ago from her current presentation, but with no residual neurological deficits. She was told to be on an aspirin, but she wasn't taking it. She had a long-standing history of hypertension, long-standing, I think, at least 10 years from what we could tell. But she had really intermittent compliance with her medications and did see a PCP, but not regularly. She did take a lot of NSAIDs at home, and she said she took that for primarily just, myalgia. She had a lot of joint pains. Her creatinine, from what we were able to obtain, her baseline was about 0.5 milligrams per deciliter. Of the limited prior urines that we could obtain, they were all bland and without any proteinuria. 1 month prior to her current hospitalization with us, her creatinine on routine outpatient testing with her PCP was noted to be 1.3. It was repeated about 1 week later, and it was up to 1.7. At that point, she was referred to nephrology, and a further workup, including urinalysis, showed microscopic hematuria with dysmorphic RBCs, and the protein quantification of the urine albumin creatinine ratio of 6.6, with the corresponding urine protein to creatinine ratio on the same sample of 13 grams per gram. Further serological workup showed a low C3 of 37, a low C4 of 5, a positive ANA, it was 1 to 640, negative anti-double-stranded DNA, negative ANCA, and a negative anti-GBM. Given the rising creatinine with her urine analysis, she was admitted to the hospital, an outside hospital, and she had a kidney biopsy that was done urgently. 1 week after, she presents to our hospital with new left-sided hemiparesis. Again, this was new, and new confusion. She had new brain imaging that showed bilateral multifocal strokes, including a new one in the left MCA distribution, left thalamus, and right internal capsule. She also had a CT of the neck done as part of the stroke workup that showed filling defects within the arch of the aorta that were thought to be potentially thrombus or plaque. Her medical history, as I mentioned, hypertension, the stroke, she did have hyperlipidemia, as well as a history of migraines. C-section previously, no prior complications during her pregnancies that we could obtain. Not smoker, no alcohol use, no other drug use, no family history. Review systems, the stated symptoms of primarily myalgia and the new left-sided weakness and confusion. Her medications on presentation, she was on nifedipine 30 once a day, Lasix 20 milligrams twice a day, Pepcid. Ibuprofen, she said she took about 1 or 2 tablets daily, and then she was on atorvastatin 80 milligrams every evening. Her exam, she was hypertensive, 154/72, afebrile. She was satting fine on room air. Overall appearance, she looked awake and alert. She wasn't in acute distress, and she appeared her stated age of 50, but she was unable to answer questions. She was confused, and there was definitely visible left-sided deficits from her new stroke. Lung exam, nothing remarkable there. She had no rub or murmur that was appreciated on cardiovascular examination. She had a 1+ pitting edema bilaterally, no rashes, no other skin lesions that we could note of. In terms of her labs, her sodium was 135, potassium 4.8, chloride of 103. had a bicarb of 24, BUN 28. Her creatinine at the time of biopsy had risen up to 1.9. Her glucose was 99. Total protein was 4.8 with an albumin of 1.7. Her calcium was 7.4. Total bili and LFTs were all within normal limits. Her lipid panel is shown there. Cholesterol 249, triglycerides 85, HDL 101, and LDL 131. In terms of her CBC, her WBC was 8 with a normal differential. Hemoglobin was 8.6 with MCV of 92.8. Her iron sat was 21%, ferritin of 141. Her folic acid was 6.1, which is a little low for the lab. Her INR, PT, they were all normal. C3 was 37, C4 was 5, ESR was 67 with a normal CRP. ANA was positive, as I mentioned previously. ANCA negative, MPO, PR3 were negative, and a rheumatoid factor was less than 15. COVID, HIV, Hep B, full profile, not just that surface antigen, but and Hep C were all negative. Her UA, she had, again, most notably dipstick protein and blood, which with dysmorphic RBCs with nephrotic range proteinuria, as I mentioned. She had blood cultures that were done that were negative ×2. She had a TTE that had no vegetations, no other remarkable features in terms of valves. Renal ultrasound at the time of the biopsy, she had 2 kidneys, no hydronephrosis. The kidney sizes were 10 on the right and 10.5 on the left. And so percutaneous biopsy was performed. So this was performed and then she was admitted to our hospital while the results were still pending.
Great. I have one question. Do you have antiphospholipid antibodies?
Not this time, no.
Okay. Anybody else have any questions?
Yeah, do you have antiphospholipid antibodies?
Not this time, no.
Great. There's a lot going on here. Casey, you wanna walk us through a differential diagnosis?
Yeah, sure. Do you have antiphospholipid antibody?
Actually, now that Casey said it, no, I still don't. Not pending.
There is a lot going on, but I mean, if you want to take this down the hypocomplementemic route, the obvious things, lupus really stands out: positive ANA, hypocomplementemia, nephrotic syndrome. So lupus, to me, with antiphospholipid antibody is on top of my list. Other things, cryo, rheumatoid factor is actually quite low. So less likely endocarditis, MPGN, those are all possibilities. If you want to take this down the nephrotic syndrome range, I think, the one that really just overlaps with this degree of hypocomplementemia would be lupus. So I think this lady, and it's really interesting because she's had so many strokes, and now this is the main feature of her presentation is she's having strokes. So I would want to get a SPEP and UPEP just to kind of look at what kind of protein she has, but I agree with everybody that this seems like some kind of a thrombotic event. I suppose she could have endocarditis and be flicking off things to her brain, and that's why she could have this. And she could have a lesion that would be related to that in the kidney, but I'm going to go with lupus with antiphospholipid antibody syndrome as my main diagnosis.
How do you feel about that? I mean, that certainly makes sense. How do you feel about that with a negative double-stranded DNA?
I feel like, none of these cases are perfect. They don't check every box. And I feel like despite the negative anti-double-stranded DNA, that still is my number 1, 2, and 3.
Great. I'd like to point out that in the chat box, Odette at 1:10 p.m. says Costanza says lupus. So for those, he was predicting the same thing quite early. For those who don't know the reference, it was a Seinfeld episode, which is rather funny about lupus. So that seems to be a kind of a common diagnostic pathway. Bill, what do you think?
Yeah, I think that's probably on my number 1 as well. I would say that usually when we think about antiphospholipid antibody and mediated injury, we're thinking about renal failure at a proportion to the urinary findings in the setting of lupus. So usually we're not seeing this much proteinuria from a thrombotic process, but lupus would cover that too. You could have a lupus membranous, or even you could have a PLA2R membranous with antiphospholipid antibodies and have both going on simultaneously. So lupus, I think, is the kind of the diagnosis that can put it all together. When it's not due to a systemic disease, other things that I would think of, I mean, she was on NSAIDs. Could it be an NSAID-induced minimal change disease with renal failure from the NSAIDs as well? That's not going to give you hypocomplementemia or dysmorphic red cells. So I think it's worth mentioning, but I don't think that's really anything. You start off with a Hispanic woman with hematuria, and you're always thinking about IgA nephropathy, but again, that doesn't really explain the nephrotic syndrome. If it wasn't lupus or it's not lupus, one other crossover between nephrotic and nephritic I think of a lot is MPGN. Obviously, most of those would be related to Hep C or Hep C is negative. If it's not due to Hep C, you could consider light chain disease as well. And we have an SPEP and UPEP that's either pending or not drawn. So I would think about that as well if it ends up not being lupus, because that MPGN gives me the biggest crossover between nephritic and nephrotic with renal failure and hypocomplementemia. That being said, I still think it's going to be lupus.
Yeah, so this is C3 and C4, which is the classical pathway, which kind of gets, I don't know, I'm going to ask Dr. Glassick in a second how he feels about taking an approach based on the complement pathway. But, you know, when I see that, I think classical pathway kind of gets me a little bit less towards an MPGN, a little bit more towards some kind of immune complex disease. Except when, you know, sometimes you get fooled and it's a cryoglobulin, which the C4 gets very low in vitro, but is often, you know, 1 or 2 or something. But we don't have cryos here, but we've got a rheumatoid factor, which is, you know, less than 15. And I don't know how sensitive that is, but in my experience, that makes it pretty unlikely that you're going to have a cryoglobulin with a rheumatoid factor less than 15. Dr. Glassick, you put some notes in the chart. I mean, in the chat. I think they went directly to me, but tell me what your thoughts are about this. Unmute yourself. There you go.
Pretty much in concurrence with what's been discussed so far with, you know, the past history of migraine and stroke. I would certainly be thinking of an anti-PLA phospholipid antibody. The very low complements, both C3 and C4, do not really strongly suggest a pure anti-PLA syndrome and would be more compatible with classical pathway activation associated with lupus nephritis. But of course, those two entities can coexist. I'm not troubled at all by the negative anti-double-stranded DNA. I think it is highly specific, but not a terribly sensitive test for the diagnosis of lupus. So I think I would go with lupus, but I'm concerned that there might be a superimposed renal limited thrombotic microangiopathy, not expressed in the sense of schistocytes and thrombocytopenia. The anemia, well, we don't know really what it is due to. Doesn't appear to be iron deficient, but maybe hemolysis or bone marrow related.
Yeah, she's pretty sick, and she has AKI. She really has RPGN clinically, and you know, that hemoglobin doesn't bother me too much because she sounds pretty sick. And, you know, it's hard to ignore all these strokes, which is what I think are putting everybody down the phospholipid pathway. And certainly people with lupus could have a small vessel vasculitis. They could also have an antiphospholipid antibody and have, you know, two things going on. Could have a GN or could have a thrombotic microangiopathy in the kidney. And so, you know, that's when I said to Casey, there's a lot of circles here and a lot of arrows. And but it sounds like pretty much people putting a lot of weight on the complements and the ANA and the Hispanic and the thrombi. And, you know, I think that's very reasonable. Steve, why don't you give us your thoughts before we go to the wheel?
Yeah, well, since this has become the biopsy case of the obscure, I'm trying to think of something that would be so far out in left field that it might actually be possible. You know, it's like Sherlock Holmes said, after you've ruled out everything else, whatever's left is the diagnosis. But I agree with that. I mean, I think we're all going down the same, you know, just by the fact we all asked for antiphospholipid antibody syndrome, antiphospholipid antibody results. The only thing I was trying to sit here and think of is that, you know, it's possible, I guess, just that her severe nephrosis with her hypoalbuminemia in and of itself may predispose her to thrombotic events. The only thing that won't go along with that is that she's had multiple of these even before now. So I think that's what kind of takes that out of the realm and makes you wonder that there's something else lurking. Because I actually have a patient right now who relapsed after 16 years and actually has had a heart attack and a stroke as a result of her severe prothrombotic state from being severely nephrotic with lupus, actually. I guess the only other thing is whether or not she has, you know, an ANCA-negative vasculitis associated with lupus causing some of these things. But again, the fact that she's had multiple of these strokes, I agree with every, I think we're all going down the path that there's something that's pre-existed here even before, you know, her presentation now. And I'm, you know, the question is whether she's been kind of smoldering or whether this is, you know, or this is just the newest onset of this and she's had antiphospholipid antibody preceding this all along. There's so many possibilities everyone's discussed, but I think for sure we're going to see lupus nephritis. I think you're going to see a proliferative lupus along with membranous. And the third factor, I think, will be some thrombotic changes from antiphospholipid antibody syndrome, or again, you can get it even without antiphospholipid antibodies. But I think with the past history, I really look forward to seeing what her beta-2 glycoprotein 1 is and some of these others.
With her strokes, you know, you brought up the possibility of strokes just from being nephrotic, you know, and it's not unheard of, but arterial thrombi are a little less common. And these would be, you know, kind of small vessel brain ones, but, you know, it's a good point. Dr. Rubin, I see you raise your hand. What do you got for us, Mario?
You know, what bothers me is the proteinuria in the sense that when I look at the fractions, there is a significant amount of globulins, and I cannot find anything that will go along with the tubular interstitial process. Therefore, I'm wondering about these proteinemic disorders, which Bill touched on, some people in the audience as well. So I'll make sure that is ruled out. And the other consideration is a C3GN here, I think, that is part of the differential as well.
And why do you say that?
Well, you know, low complement levels have been described in this condition. It has, I know that Dr. Corbett doesn't like this term, but I do. It has a nephrotic presentation. Therefore, you know, I think it's a possibility among the entities to be considered in the differential.
Actually, I don't have a problem with that combination. I don't know where I got that rap from, but I agree. I think the two things can coexist.
Yeah, I think I love still using it. I think it's extremely useful clinically in teaching and otherwise. Is C4 often low in C3GN? I don't really know. I always think of it as isolated C3.
When you look at the data that Andrew Bombach has written about it, primarily, you know, you can have both fractions low, neither of them could be low, so anything can happen.
Wonderful. So let's get the wheel going here. Let's see what we got.
Awesome. Hold on one second.
Awesome's one of our second-year fellows. He's going to read the biopsy for us.
All right, so we start with the low power trichrome stain looking for chronicity. We have two cores here. Both of them seem to have some bluish material. The tubules don't look extremely back to back, so I think there is some fibrosis, but not a lot, maybe 30% or so.
Yeah, that's what I estimated, about 30–40%.
Okay. Yeah, sounds good.
And we usually don't comment at this power on the glums, but awesome. But what do you think about the glums? I'm not going to ask you anyway, just because it's something kind of looks.
Yeah,
suspicious.
I mean, at low power, even here, they look kind of lobular in appearance. So we'll see better on the higher power. All right. So we have an H&E stain here, kind of high power, medium to high power. We have two glums in the middle. Again, what's striking is the lobular appearance of both the glums. There is some degree of mesangial expansion as well. Yeah, and then I don't really see any crescents. The Bowman's space seems pretty open. There are some areas of mesangial hypercellularity as well in both of these glums. Yeah, so probably lobular appearing.
The only other thing I would add is I see actually, sclerotic nodules as well,
Right.
especially in that one there. Yeah, it looks nodular.
Right.
Yeah.
Yeah.
Yeah, I mean, if you didn't know this, if you didn't know all this serologic stuff, what would your first thought be? Awesome.
I mean, that looks like diabetic, not
Yeah. I mean, we know he's not diabetic, but
Right.
she's not. But I mean, that's at least one. There's other things, obviously, in the differential. But yeah, I mean, to see that acellular nodule.
Mm-hmm. Right.
Yeah, and then there in the interstitium, you could see some fibrosis and tubules becoming a little atrophic. Yeah.
Right.
Okay, good. There we go.
All right. So there's another high power H&E stain. Again, on the left side, we can see there is, lobular appearance with a nodular appearance as well. And there is kind of, scarring here. Again, areas of mesangial expansion. On the right side, I do see another glom. That seems kind of bilobular to me, but again, pretty much the same appearance. I'm not sure these red blood cells, should we read it as like a thrombi in this glom or?
No, those are just unlicensed red cells.
Okay.
But actually, there's one capillary loop if you go at 11 o'clock on that glomerulus on the right.
Right.
And go up to 11 o'clock. Yeah, right there. Yeah, look how thick that capillary wall is. That looks massively thickened.
I see.
Kind of like a wire loop.
Yes, yeah.
Okay.
Yeah,
This
and then
thing,
look at and then in comparison, look at the capillary loop down at over 3 o'clock. You could see over there, that's the normal thickness.
I see.
Yeah.
Beautiful. We'll point out, in the differential diagnosis of lobular non-diabetic, you always think about smokers, and this is a non-smoker. Just wanted to point that out.
I see.
And David, it may be too early. I don't really see it here, but do you see the afferent or efferent arteriole? Because we are thinking, just important in the concept of nodularity. Was there any hyalinosis on any of them, David?
Oh, well, yeah, no, not of both afferent and efferent. On that, over where the arrow is, you could see part of a arteriole there that maybe has a little mild hyalinosis.
Okay. All right. Another one of the H&E high power, again, nodular and lobular appearance of the glom with mesangial expansion. Just looking for the, we talked about the GBMs. Here, I think there some component of like endocapillary proliferation as well here, these spots or?
No, I think the mesangium is so expanded and sclerotic, it's kind of compressing the loops, and compressing them so that it's not cells, proliferation that's filling them. It's more they're being compressed and crowded out by all this sclerotic matrix.
Okay, I see. Yeah, I mean, again, these are again some lysed red blood cells as we discussed previously. And I think that's.
Yeah, and then again, around the glomerulus, you got that fibrosis there in the interstitium. Yeah.
Right.
Hey, Austin, what else is in your what else is in your differential diagnosis of something that is this nodular?
I mean, as you mentioned, one is the idiopathic, as you said, or diabetes. These are the two major ones. And then again, I think if there is nodular appearance, then it has to depend on the immunofluorescence pattern. And it can be C3GN still if we have the C3 positive, or it can be an autoimmune process as well if we have both C3 and IgG. So that's what I would say probably. And then again, you can have monoclonal paraproteinemia as well, depending upon the light restriction.
So what do you think about amyloid looking at the stain that we're presently looking at?
So it should have, I mean, if we talk about like weakly positive PS stain and amyloid, and here it seems to be staining pretty, it's pretty, sharp. So I wouldn't pick amyloid, but I think we have to look at the Congo red stain as well to be definitively saying.
Yeah, you're right, Awesome. Yeah, this is strongly PAS positive, and Congo red stain was negative for amyloid, so that's excluded.
Okay.
Just one side point. I mean, Roger brought up the issue of ING, which was originally described, I think, by Dr. Agati at Columbia, and we have discussed this in the past. But my point is, in that paper, there is an outstanding table that provides an excellent differential diagnosis of what we are looking at. So it's a must read for the fellows.
We'll pull that up and put it in the link later. Thank you.
All right, so here we have the Jones or silver stain. I think this arrow, is it pointing towards a double counter, maybe?
Yeah.
Okay. Yeah, so there is some spreading of the capillary wall here, probably. And again, there is the nodular appearance here as well. And in this part, it's just GBM kind of is splitting a double counter, which makes the MPGN pattern more definitive here.
Yeah.
David, is there any evidence of mesangiolisis here?
No, it seems to be all the same intensity here.
All right.
Yeah.
Thank you.
So, Awesome, have we seen any evidence of TMA yet?
No, I really did not, apart from some lysed red blood cells, we didn't have seen any thrombi there in the vasculature yet.
So our two main diagnoses in the discussion were, lupus with possibly an RPGN or a very extensive TMA, and we haven't seen either of those.
Right. Cool. And again, on the left side, this is kind of more classical, the double contouring goes along with the MPGN. But again, as Dr. Baxi said, we don't really see any crescents here in this whole slide so far.
MPGN is, I believe MPGN you can see associated with thrombi, but we don't see the thrombi, right, David?
Right. I didn't see any thrombi in the capillaries or in the vessels.
Mm-hmm.
So the most prominent thing at this point is really that marked mesangial nodularity that's PAS, fairly positive, strongly PAS positive.
Mm-hmm. Right. Then we're looking at the tubules here. Again, I don't know, there are some spots where there might be some sloughing off, but other than that, the tubules look healthy to me. Here.
Right, yeah, there's ATN. You could see some sloughing off and the loss of the PAS positive brush border.
Right.
And then there's an arterial there at like 2 o'clock that looks widely patent. Yeah, right there. Yep.
This one, right. Okay.
Yep.
All right, so that's what we were kind of waiting for the immunofluorescence, and that's pretty strongly positive for IgG.
And it looks kind of to be everywhere.
Right, kind of pretty diffuse.
Capillary wall. I see some in the clumpy mesangial area down at the bottom, and even in the tubular basement membranes too.
Right.
Yeah.
So Dr. Gashti in the chat says the IF should make the diagnosis if it's restrictive or not, meaning light chain restriction. So I think we need a drum roll at some point. I assume that's coming up pretty soon.
All right. Same goes for C3 as well. I think it's pretty much the same distribution as the IgG. A little bit less maybe in the mesangial area, but we do see it in the capillary walls as well.
Yeah, so it was not full house. IgA and IgM were negative, and here's the kappa lambda.
Wow. So we don't really see any restriction of either one of the two strains.
Mm-hmm.
So we can't really call it the monoclonal gammopathy.
Right.
David, the Congo red was negative, right?
Yes.
Okay.
Right, and then we have the EM here. Just to orient ourselves, I think this is more so the capillary, the blood space. Here outside we have the urinary space. Here I do see, again, there is a splitting of the membrane here as well, maybe around this area where there is some deposit probably here, more so in the subendothelial area.
Yes, yeah, and then there's mesangial interpositioning where you were. Yeah, right there. Yeah, that cell process there is belongs in the mesangial area. So that's the duplication we saw on the silver stain.
Right. And then the podocytes themselves, I mean, here they look pretty intact, but maybe there is some focal effacement as well around this part.
Yeah, it looks partial to diffuse. Yeah.
Okay.
Yeah. How about in the mesangial area? Do you see that? And are there deposits there?
Maybe around this part, and
Yeah.
there are some light deposits as well in the mesangium too.
Yeah, and if you keep going up, all that matrix and deposits, yeah, that's all that mesangial expansion we saw on the light.
Okay. All right. So again, this is probably the blood space. Here, maybe we have a red blood cell, if I'm not mistaken. Is that an RBC?
Yep.
Okay. And then the GBM itself, again, we do see some deposits in the GBM as I go along this one. There's some probably again here as well, some deposits in the mesangial area as well. But predominantly we have the deposits in the glomerular basement membrane.
Yeah, and mesangial interpositioning and duplication also. Yep.
Right.
Okay.
Yeah, I think here is probably much more prominent. Again, I see the duplication of the glomerular basement membrane here.
Yeah.
Yeah.
Now, I think is there one more EM? Yes. So the deposits were granular and not organized. So I couldn't diagnose fibrillary or immunotactoid.
Yeah, good, David, because somebody brought that up in the chat. They look organized to you, or just kind of?
Yeah, right. I mean, they look
granular as a term.
kind of, a little different than our typical big clumpy deposits. But when I go, they looked at, there was no substructure to them.
Okay. So, Austin, we're not going to ask you for clinical diagnosis. What's your histologic diagnosis?
That goes along with the membranoproliferative GN with both C3 and IgG positive on the immunofluorescence.
So, Casey, how do you put this together?
Yeah, I mean,
Do you think this fits our lupus?
No. It's kind of hard to put it together. I mean, it's MPGN, right? So, I mean, lupus can have an MPGN presentation. It's just that it's not obviously full house. It doesn't have to be always, but those deposits kind of bother me, the way they look, and obviously there was no TMA to suggest antiphospholipid. Doesn't really explain the strokes or any of that stuff clinically. So I'm gonna presume this is MPGN, you know, so the work, the differential on MPGN would be still paraprotein related, viral, which, you know, we've sort of ruled out Hep C as the most common one. I do want to still see the SPEP and UPEP. That to me, I think is the next best step, because you know, even though there was no protein restriction or light chain restriction on IF, you know, there are some cases where you know, you can have, you know, sort of, I suppose, a false negative. So I want to see what the SPEP UPEP shows and kind of go from there.
Before we hand it over to Dr. Bexey, anybody else have any thoughts?
I gave a C3GN lecture to GlomCon, and sometimes the immunofluorescence pattern of the kappa and the lambda restriction can be really revealed that there actually is a restriction if we do pronase digestion. So I don't know if we were able to do that in this case or thought of. I kind of only think about it in funny cases, and this sounds like a funny case to me.
Great point. Yeah. And
Although the IgG was strongly positive, though.
Yeah, and I'm not saying that this is C3GN. I'm just saying I wonder if pronase digestion may reveal that there's a actual monoclonality restriction, and maybe this is really a myeloma or a light chain deposition disease of sorts.
Well, or like you say, I have a case that the pronase made all the difference, and it was an IgG cap, I believe. So it was the monoclonal gammopathy of renal significance, essentially. But he never had a paraprotein. I mean, he's one of these people that had an MPGN-like picture, and it ended up being a result of you know, a monoclonal protein, but you know, the tests aren't sensitive enough to find it in the serum or the urine. But for 2 biopsies prior, he was being diagnosed with just MPGN because kappa and lambda both were positive by fluorescence without the digestion. The thing that's weird to me about this still is this mesangial expansion that looks like amyloid and you know, all the other diseases we've talked about. Just MPGN in general, I just don't realize, and I don't remember seeing something with that kind of major expansion where it looks like diabetes or idiopathic nodular diabetes. I mean, that to me is still the conundrum as to how you put that together with the rest of this.
Yeah, that's kind of what I'm thinking. It may actually be a light chain deposition disease if there is a restriction after pronase digestion.
Well, I
remember
guess
the
go ahead.
The IgG was somewhat in the tubules.
Well, you can have light and heavy chain disease, right? I mean, you just have to show.
Regardless, I'm just saying, you know, it's not something we typically see in tubular. David, did you see any deposits? Any of those deposits in the tubules?
Well, they talk about it being granular. So and that's when he brought up that word. I mean, with light chain disease or even it's a granular appearance to it. It's not like electron dense deposits.
No, I know, but I mean, you in a light chain or heavy chain, light chain, you might see them in the tubules as well. I was just wondering, because we saw the immunofluorescence there. I was wondering if the EMs correlated with it.
Fair enough.
No, I didn't see any he takes a couple pictures of the tubules. I didn't see any deposits there.
Well, a lot of good questions. I think it's a lot of people are getting back based on the pathology of this being so nodular, even though it's not restricted, the possibility of paraproteinemia. So, Praveer, tell us what you did next and how you.
Yeah, so this is just coming back. What are the thought process? But I agree exactly what Dr. Corbett was saying in terms of it. Just something seemed off. But first of all, if you're going down the MPGN pattern, the classification that we use in terms of immune complex mediated, complement dominant, or negative immunofluorescence, this would fit into it was positive IgG and C3. So it was immune complex mediated MPGN. And of those, your differential becomes monoclonal gammopathies, which we still talking about. There was no light chain restriction. Autoimmune diseases, which we thought maybe this would be more of the case. It seemed more autoimmune. These strokes, young positive ANA infections. We did a thorough, multiple blood cultures. She actually had two cardio echograms. Nothing of that sort that was there. And then finally, you group this into this weird, idiopathic where nothing else is fitting. And so, initially this would become one of these immune complex idiopathic. But as everyone mentioned, that nodularity the whole thing just seemed something off. And so when, when we got the report, Dave, Dr. Simbaluk, we kind of sat down and said, there has to be something else. And, let's just check, what else can we do? So we did send off SPEP, UPEP. And, the next step was, let's send it out for pronase digestion and further evaluation, because that was really the biggest thing. And so sure enough, we send it off to Mayo Clinic, the SPEP and UPEP are pending. And we get this back from the Mayo Clinic. So what we see here is, IgG, and David, you can it was definitely positive and after pronase digestion, but what we found was there was lambda restriction. So sure enough, on pronase digestion, we had a monoclonal, IgG lambda. So it was masked. And sure enough, while this is going on, we got our SPEP and UPEC back, and that also showed a monoclonal IgG lambda. So it turned out to be that she had a monoclonal protein in the blood and in the urine that correlated with her biopsy, and in our routine immunofluorescence did not detect it. So it was one of those masked cases. So this finally, the final diagnosis here was light and heavy chain deposition disease, and the subtype was IgG1 lambda, which again correlated with her serum and urine studies. So, the whole thing that everyone brought up with, the nodularity, I agree, it just didn't seem to be, what you typically see. So at that point, we got hematology on board, and we were able to get a bone marrow biopsy, and sure enough, it showed hypercellular marrow for age involved and it was 15% plasma cell neoplasm, and it was again lambda light chain restricted. So now you have this perfect story of biopsy of the bone marrow, the kidney, and the serum urine all showing lambda restriction with IgG. So now we go from a case of idiopathic MPGN to more or less myeloma, given the criteria here. And really, it kind of changed the whole process here. So, why is this? Why? The question for me was, why does this happen? Why do we have to do these pronase digestions? And so, going to our standard immunofluorescence, this has been around for a long time. And what we do is they basically take unfixed frozen tissue, and you take cryostat sections, and you run the test. But this is not always successful. Sometimes you don't have enough glomeruli, or have no glomeruli in those samples. With our biopsies, when we do them, it doesn't have to go into any medium. But when we have outside biopsies, they're actually transported in this transport medium, the Michel's medium, which we'll get to, may play a role on why sometimes we have masked deposits. So this whole idea of paraffin immunofluorescence it's something that's not new. It's been around for a while, and it usually has been developed as a salvage technique. So when you have immunofluorescence and you get the tissue, there's not any glomeruli, you can go back to the formalin fixed paraffin embedded tissue that you have and perform pronase or proteolytic enzymatic digestion on that as a salvage technique. So it was really developed as a salvage technique. And so what you do is that, here's the steps. So first of all, this tissue is formalin fixed. And so what that does is that induces protein cross-linking, which generally blocks antigenicity. So once you have this formalin fixation, you need to then do another antigen retrieval step that will allow the antigens to be unmasked, and then you can actually have antibodies that can detect it. And so this antigen retrieval step is done by two methods. One is proteolytic enzyme activity, the other one is heat. We'll focus on the proteolytic enzyme activity. So you basically incubate these formalin fixed, paraffin fixed sections with these enzymes, primarily pronase, but people have also used proteinase, trypsin, and this will allow you to increase the penetration of antibodies to the antigen. So that's the overall process of how this works. So again, it was used as a salvage technique, but it becomes important in this case, and this is kind of how this really the important paper for this, and this is came out of Kidney International in 2014, and they basically looked at these patients who had MPGN pattern of an injury, just like our patient, with monoclonal IgG deposits there was no light chain or any restriction on the routine immunofluorescence, but they did have on this formalin, paraffin, pronase digestion, they did have they had evidence of a monoclonal IgG. So in 10 patients, these patients previously had a C3GN diagnosis because, again, there's no light chain restriction. So it changed the diagnosis. These patients typically presented with hematuria, full nephrotic syndrome, renal insufficiency, and hypocomplementemia, which fits our case perfectly. This is exactly how she presented. And so that's one case, that's one usefulness of this procedure. The second part is there's also this entity of membranous-like glomerulopathy with masked IgG kappa deposits. So this is another instance where, you know, this technique of pronase digestion on this tissue unmasks further immunofluorescence or changes the diagnosis. In these cases, these patients, what they did is they had 14 cases, and these patients had large subepithelial deposits by electron microscopy, but the predominant staining on immunofluorescence was C3. So, you know, it looked like membranous, but the IgG on these were really not really positive. So when they ran this test through this pronase digestion protocol, sure enough, they found unmasked IgG kappa. And so it was interesting because these patients then fit like almost a membranous type picture. So they had, and here's so this is kind of the example here. So this is the normal immunofluorescence, and this is the one with pronase digestion. You can see how it really reveals the IgG, and this fits more of a membranous-like nephropathy. Now, it's interesting here, and I don't completely understand, I don't think we do, is why these patients have a monoclonal IgG kappa. Many of these patients don't have, you know, a monoclonal protein that's found, and these patients are typically young and have some vague autoimmune phenomenon, but they have this membranous-like nephropathy. So this is a new entity that doesn't really fit into our current classification. It doesn't really fit the, you know, typical membranous, and doesn't really fit the MGRS completely either. But, you know, it's its own entity. The good news is these patients typically do pretty well, and some of them can even have spontaneous remission. But, you know, this is where this whole
I want to stress the point that the first paper is really about what we have here with our paraproteinemia patient, and this that fits. In the second paper, although it is mass deposits, these patients are typically do not have a monoclonal gammopathy or paraproteinemia, yeah. And it's hard to say what to make of these, but that's yeah.
Yeah, and so why is this happening? That's another question. So sure enough, this happens, and we have, you know, it's a known entity, but why? Why is this that, you know, our routine immunofluorescence doesn't detect like restriction? Because it's a big deal. It changes the whole diagnosis and your workup and treatment. So there's proposed mechanisms of mass deposits, and these are the three potential ones. One is that the antigen epitopes may not be available for binding, and this may be due to the way the tissue is processed. Some of these tissues, like I mentioned, may be washed prior to running the immunofluorescence, and this may also alter the protein structure. So, you know, changing the structure, the tertiary or structure of protein may disable it from actually binding to the antibody, so that may give you a false negative. Another big category where you see this are these crystalline and light chain proximal tubulopathies, where what happens is because of the crystallite structure of the deposits, these antigens are really not able to bind. And so the antibody can't get to these sites easily. And so you get another false negative. And finally, there may be interference from the transport media. And that's what I bring in terms of outside cases. We run it in these transport fluid mediums, and these may actually cause interference with the reactivity. So you may get a false negative. So overall, do we know how these happen? No, but I think, you know, the whole idea of altering the structure, or if it's hidden, that makes sense of why these may be masked. And by treating the tissue with pronase digestion, kind of reveals, and maybe it allows these antigens and the epitopes to be more available to binding. And so that's really the best explanation for this. So when should we do this? Should we do it in all our patients? Should it be routine? Well, there are instances where, you know, it's not the best test, but these are the indications for, in terms of literature, which we should at least consider it. Of course, in our case, when we have an MPG pattern with negative staining of IgGs, or maybe an idiopathic case with atypical features, then you should really be looking for this mass deposit. So that's our case, but also other scenarios, if, as I mentioned, patients who have a light chain proximal tubulopathy or they have a crystalline induced nephropathy, it'd be useful to run these. This is primarily the salvage technique. So if you do have frozen tissue and you don't get enough glomeruli on your immunofluorescence, you can hopefully run this if there's no other tissue available. And also C3GN associated with monoclonal gammopathy. These patients who have atypical findings that don't fit your C3GN typically, and maybe they have don't have subepithelial thumbs, or they only have slight electron density, you may want to run this pronase digestion to see if there is a unmasked monoclonal protein. And then of course, I mentioned the membranous nephropathy, that's with a masked IgG, and then fibrillary GN, again, looking for a monoclonal gammopathy or a monotypic IgG deposit underneath that. So, you know, for us, what we end up doing is here, we were able to run this with the help of David and Mayo, and we were able to get a diagnosis of a monoclonal, really a myeloma here. So the next step here would be, you know, chemotherapy. And that's kind of where we are with this patient right now.
So I want to tell you a little the story behind this, because this patient was, you know, biopsied elsewhere, and then got admitted to Rush with this new stroke. And, you know, Pravir came over and he said, you know, this is weird MPGN, and I don't know how to put it together. We went back to the charts and kind of what he did, and, you know, talked about the differential, one of which is monoclonal, not something, you know, it was very high on our radar clinically, and said, well, we just better send it off. But started talking more about it and brought up the concept of this, you know, the pronase digestion, which, you know, we talk about all the time, but to be honest, this is the first one that we've sent out for that. And fortunately, Mayo was absolutely fantastic, and they got us an answer very quickly, and Dr. Nasser was, you know, extremely helpful in getting us the information. So, you know, this is, and, you know, we're a major institution, and so this is kind of the evolution of these things. You read about them, you talk about them, and then you learn about them, and then you do it yourself. See one, do one, teach one, and then, you know, from now on, it'll be almost routine. I don't know what we'll do it on, but I think the point I wanted to make is that, you know, Pravir realized that there was something off about this case, and we weren't just going to stop at MPGN, because had he stopped at MPGN, this woman would not have a diagnosis of multiple myeloma. You know, it just gets down to basic good thinking and following through. You know, as we talked about it, everyone kept saying lupus and micro thrombopathy. You know, Dr. Rubin, Mario, you know, he kind of stuck his neck out a little bit and wanted, you know, he had a few more clues and wanted to go down that pathway earlier. So I think Mario, you get the designation today of being Super Mario. Congratulations. I think Dr. Glassick had to leave. He's always super, so I can't really give him any credit. I will open it up for anybody else's discussion. I think this was as much a learning case for us as it was a therapeutic case for the patient, and for everybody involved, because I don't know 6 months ago that the words pronase digestion ever came up in a biopsy conference, and we've been doing this for 40 years. And I think this is going to be something that is, you know, just like mass spec looking at deposits, you know, to see what they're made of. We're going to see more and more of this coming out as we become more and more sophisticated.
And without light chain restriction, hematology may not even do a bone marrow biopsy. They may just say, no, there's no, like, we don't need to pursue it. And so the fact that you were able to get this would probably give a little bit more ammunition, say, hey, listen, hematology, we really need to get this biopsy. And then look what happened, you diagnosed myeloma. So unbelievable, amazing use of pronase digestion to really save the day.
Deposition disease a few weeks ago that had significant hypocomplementemia, and, you know, we got pulled down that pathway. And I remember Dr. Glassick saying, you know, I really have to add, you know, monoclonal gammopathy of renal significance to my list of hypocomplementemic GNs. And I mean, this is another good example of just how profound this hypocomplementemia was, and it's not our, you know, our old list. You know, we have to educate our hematologists too, because they're, you know, they've got these myeloma criteria that are very strict, and they're not quite used to some of these paraproteinemias that are so subtle otherwise, that are presenting only as renal disease when they don't have hypercalcemia or bone disease or bone. This patient had no lytic lesions, I believe.
Yeah.
You know,
any other comments?
Yeah, what's interesting is how to approach these MPGNs, and I think the slide that Pravir showed, which is the K-Vigo algorithm for MPGN, is very useful. I mean, on the basis of immunofluorescence, if you have immunoglobulins and complement, you lean towards certain group of diseases. If you have complement only, you lean towards the C3 and the dense deposit disease. And interestingly, Frank Brideau from Paris, at the ASN, I think was 2 years ago, gave an outstanding lecture on this particular entity and call attention to the fact that if you have patients and the cutoff they use was an age of 55 and above, you need to pursue the possibility of this proteinemic disorder underlying this disease. And there is excellent immunological work on the part of Sophie Chevet that works with that group in Paris. And as Roger pointed out, these conditions can have an associated hypercoagulable state as well, which might explain the strokes in this lady. So great job, Pravir. Kudos to you. Fantastic.
The last thing I want to say is that, getting back to this figure here is, Dr. Whittier is the one that really kept turning me onto it. So he kept going back to it. Now, it's literally in my, on my phone, because it's such a, when you talk about MPGN as a pattern of injury, it's one thing to talk about FSGS as a pattern of injury, but MPGN, talk about a diverse set of diagnoses that I never want to miss anything. So I go back to this all the time, and I think it's extremely useful. And had we not had this, or, I'm not sure that this was available, 10, 15 years ago. I remember a case, I'm going to end it with this, a case of a patient I had as a fellow who had MPGN, bad MPGN. And we did everything we could do back then, which wasn't very much, to work him up. But then, a few years later, it was realized that Hep C was a cause of a lot of MPGN. And so I brought him back, and his Hep C was negative. And then a few years later, we realized that some monoclonal gammopathies were related to MPGN. I brought him back, and he has no monoclonal gammopathy. Now, he's been long lost to follow-up. But I wonder now, if we would do two things which would increase the sensitivity. One would be serum free light change, which markedly increases sensitivity for picking up a monoclonal gammopathy, and pronase digestion, because I wonder if this isn't what he had all along, is he had a monoclonal gammopathy of renal significance that we were never able to diagnose because we didn't have the tools back then. He was left with a diagnosis of idiopathic MPGN. So, we've come a long way, but we've got to take this stuff and continue to go further. Great case, everybody. Great job, Pravir. Nice discussion. Thanks everybody for discussing it. We'll be off next week. But we'll be back the week after. Everybody have a safe Thanksgiving and a great week, and we'll see you soon. Thank you.